Hazel came along today for a general skin assessment. She spent many years in North Queensland, has had a lot of solar damage in the past, a lot of sun exposure, and she was particularly concerned that a number of these lesions that she's got could be skin cancers and have long-term consequences. So today we're concentrating primarily on her hand and some of the lesions on her face, and I'll start now with some of these areas on her hand. When I examine the skin, I almost invariably wear one of these magnification loupes. I find that it gives me two hands free to do any of the procedures, and the magnification is of great assistance when you're looking at these lesions. So, okay. The first thing I do when I look at these lesions is to just assess the background skin texture initially. It's obvious that looking at Hazel's hand, she's got a lot of solar damage spread diffusely over the dorsal aspect of her hand, which is in most of these patients one of the commonest areas where they get the solar damage. And then, having decided that yes, the general background skin's consistent with solar damage, then you go and have a look at each individual lesion that she's got. Hazel's got a number of various skin types here. She's a number of various lesions here. She's got the typical well-defined little solar keratoses, these areas here. She's got a more darkly pigmented lesion here, here and here, and you have to look at those more carefully to decide what they are. On closer inspection of this one, it's well defined and it's completely flat. There's no induration when you feel the lesion, and that'd be consistent with the solar lentigo. On these other two little lesions here, and in particular this one here, she has some superficial scale over the area which easily peels away, and I'd call that a pigmented solar keratoses. Generally speaking, you have to be fairly certain the diagnosis before you'd embark on cryotherapy with any of these pigmented lesions, and if there was any doubt, I'd advise that you do a small little shave biopsy of the lesions. With regards to some of the other areas, this area here is much larger than these ones, and the scale is much thicker, both to look at and to feel. And when you pick up the lesion in the skin, there's some depth to that lesion, as opposed to these lesions here, which are much more superficial. So clinically, I'd say that's an early intraepidermal squamous cell carcinoma. The differential diagnosis would be a hypertrophic solar keratoses, and depending on the induration, if the lesion was any thicker, then I'd say it was a well-differentiated squamous cell carcinoma. So if we're going to treat these lesions, the solar lentigo doesn't require any treatment, but these other lesions I would treat. The chances of them developing into SCCs is still relatively small. However, in someone who has widespread solar damage, the possibility still exists that they will evolve into skin cancers. And at this stage, they're quite easy to treat. I'm going to treat them using cryotherapy, and at this clinic we have liquid nitrogen available, so that's the treatment of choice for this area. When using cryotherapy to treat lesions, often it's necessary to treat the lesion using a cone. The advantage of the cone is it gives you a better depth of freeze. They come in various shapes and sizes, and various manufacturers make them. These ones here have been made from silicone using just a simple mould technique. The main part about selecting a cone is that you choose a suitable diameter so that when it's placed over the lesion, when you look down through the top of the cone, you can see all margins of the lesion. This cryoc unit has interchangeable nozzles. We generally use the size A nozzle for the lesions on the hands and arms. However, it has smaller nozzles down to size D for fine work around the face. It also has a cryoprobe that can be used for ophthalmological purposes when freezing small lesions on the eyelids. I'll initially freeze these areas here. When freezing a solar keratoses, although there are set guidelines describing how long the freeze has to be and how long the area has to be remaining frozen, these guidelines often have to be varied according to the site, the age of the patient and the type of lesion that you're using. But in general, the solar keratoses should be frozen so that the area remains white and is a solid region when you compress the skin for about 15 seconds or more. Okay, so we'll start with this little one here. I always freeze them so that the area goes beyond the clinical margin of the lesion. When it is frozen, it's often easier to see the spot and where the lesion ends than prior to freezing it. Usually also when the area's been frozen, within about 60 seconds to 5 minutes, you notice that there is already some small edema forming under the lesion, which is a good indication that you've frozen the lesion sufficiently. It does sting, and it's good to advise the patient that the stinging doesn't go on for very long. After the stinging subsides, it's often quite itchy for the next 20 minutes too. So after it's been frozen over the next few days, you'll get a blister in the area. It's not necessary to do anything to that blister. It'll just gradually peel off after about 5 to 7 days. And you can get your hand wet, just avoid soap and irritants directly on the skin. I'll just come round and just freeze this little area here. And that's it. Right. With this particular lesion, the intraepidermal carcinoma, I'll just draw an approximate margin for where I'd expect the freeze to go. Generally speaking, if the lesion's a carcinoma, you should allow between 3 and 5 millimetres freeze around that area. With the basal cell carcinomas, it should be a 5 millimetre freeze, but again it varies slightly depending on the type of basal cell carcinoma. If it's a nodular basal cell carcinoma, then a 5 millimetre margin is recommended. If it's one of the superficial basal cell carcinomas, then depending on the site, perhaps that margin could be slightly smaller. With this one, I'm going to freeze it using a cone. The advantage of using the cone is that you get a slightly deeper depth of freeze. It can be frozen without using the cone if it's an intraepidermal carcinoma. Just to judge the cone size, it's just a matter of selecting one that when placed over the lesion goes basically around that outline that I've just drawn. And it's a matter of putting it over the patient and freezing down the cone. It does hurt more for freezing. If the lesion's frozen twice, the cure rate is increased. By freezing the lesion once, see, that's not sufficiently frozen on that, you haven't got enough margin, so I'll just freezing the lesion once results in about a 90% cell death of that tumour. Freezing it twice increases that by a further 8 or 9%. The whole idea is when it's frozen to pick up the little area that you have just finished treating, and it should feel like a little ice ball underneath the skin, which that one does. It's also a clinical way of just judging the depth of that freeze. Other methods can be used, for example, thermocouples, which will give you exact temperatures at certain depths under the skin, but practically that's not something that's used for the majority of the lesions that we freeze. It can be used in certain circumstances where you want to be sure you've got to a certain depth. And that's starting to defrost, so we'll just keep that frozen for a little bit longer. It has to remain frozen for approximately 90 seconds. If it does start to defrost on the edges, then it's quite simple, as I did then, just to refreeze it so that it remains an ice ball to the margins that you've already decided. Right, we've now waited approximately 90 seconds and that lesion's thoroughly defrosted, and I'll just give that another freeze. Again, you can use the cone to give it a second freeze, but on this occasion I'll just do it without the cone. It's a matter of starting in the centre of the lesion again and freezing to the margins that you've decided. Usually on the second freeze it's not as uncomfortable as the first freeze because the liquid nitrogen does give some local anaesthetic properties to the skin, so on the second occasion it's not quite as uncomfortable as the first. Right. And again that lesion will remain frozen for approximately 90 seconds.